what I would like to do is talk to you about disparities in health and then what we can do about them. And I understand that we have about an hour for this, and so I will certainly not take up the hour, but also I'd like it to be interactive, so if you have questions while I'm speaking, please just stop me and we can talk about whatever is of interest to you, okay? And I also don't mind at all if you disagree with anything I have to say, just please shout it out. In fact, if you don't disagree with what I have to say, then you're weird. So I'll tell you about it. So here's the outline I'll follow. I'll talk to you about disparities in health and some data we've used to think about it. And then the last couple of topics talk to you about measures we've taken, steps we've taken to try to make things better and to change them. So it's interesting, I know you're not all public health people, but when we think about public health, one of the main themes that runs through public health for the last 30 years or so is our efforts to try to reduce disparities, that is difference in health status between different groups and all different kinds of groups. And the federal government has put that high on its agenda, being forced to do so, by the way, by the civil rights movement, which raised these issues many years ago. And so the federal government now says it's trying to reduce disparities and in fact puts a lot of money into that reduction. But there is no real paradigm or model for examining disparities. I mean, we could do it for one disease at a time, diabetes or heart disease or asthma or something like that. But if you want to know, are we making progress as a society in reducing disparities, there's no real model for examining that. So I work at Mount Sinai Hospital, which is just down the street from here. It's a safety net hospital. We're in a very, 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 very poor neighborhood, which is about half black and half Mexican. And everybody we serve is very poor, and as a result, the hospital is very poor. But we have a group there called the Sinai Urban Health Institute. And my colleagues and I wrote a paper quite a while ago, 2001 now, in which we tried to establish a model for determining how we can figure out whether we're reducing disparities. By the way, I'm going to be showing you some papers and some findings. All of them, 100% of them, are on our website. And the first slide has our website right there. And if you go there, you could find all of the papers in PDF format. And Ronnie's going to make these slides available to you, so if you want them, they're yours, but certainly our website will be available. So this was the first paper we wrote, trying to establish that model. And the first effort, it was a nice one. That's the front page. It appeared in this journal called Public Health Reports. And after we wrote it, some people comment on it and generally liked it. And a few years later, in 2004, we tried to improve on that model and wrote a second paper in the series by mostly the same colleagues. And that was published in the American Journal of Public Health. That's the front page of that. And then finally, we've more recently written a third paper in the series, all based on our thinking improving and other people making very important suggestions and writing other papers. And I'd like to go through this paper now in some detail with you. So here's what we did, was we said we wanted to look at disparities in Chicago, and we chose for this paper just to look at disparities between black people and white people in the city of Chicago. And what we did was we took 15 different measures, they're called health status indicators, and we said that we would compare the differences between black and white people in 1990 and then 15 years later in 2005, which was the last year we had data for. So non-Hispanic black and non-Hispanic white, you know that terminology, just to take out Hispanic people whose race is either black or white, but we remove them from the analysis. So these are just white people who aren't Hispanic and black people who aren't Hispanic. And then we compare them in 1990 and then in 2005, and we did the same thing for Chicago and for the United States. So that was the model that we used. There's the cover of it. And now this is a test. How many measures did I say we used? Okay, so 10 of them were measures of mortality or death, and here they are. These are the usual measures. People would generally agree on them, you know, maybe put 1 or 2 in, take 1 or 2 out, but these are the usual causes of death. So how many more do I have to show you now? All right, this is Shirley, give them all A's, okay? So 3 of them were measures of birth outcome: infant mortality, low birth weight, and no prenatal care. And how many more? Okay, and they were communicable diseases, infectious diseases, primary and secondary syphilis, and tuberculosis. So those were the 15 measures that we used. I won't go through the statistics. So here's our first finding. So one of the measures was all-cause mortality, the overall death rate. And I'll spend a few minutes on this because then that'll orient us for the rest of the graphs. But here's how it worked. So in Chicago in 1990, and colors aren't so clear here, but the top line is for black people. And as you can see, the black death rate overall is 36% higher than the white death rate. That's very high. That's a big difference. And that was in 1990. And then by 2005, that difference or disparity was 42%. So had the situation gotten better or worse? It's gotten much worse. So it's gone from 36% higher, the black rate, to 42% higher. That's an extraordinary difference. Notice, for those of you so inclined, this means the asterisk that the difference was statistically significant. But it's a very big difference. Now, notice that what we're talking about here, what we're focusing on, is the disparity. Both rates went down, which is good. So the death rate for both white people and black people went down, and that's wonderful. But the rate for white people went down even faster. And so what was already a big disparity got even bigger. Okay, and that's bad from any number of points of view. Okay, for heart disease mortality, you see the same general thing happening. In 1990, the rates were almost equal. And then by 2005, the black rate was 24% higher than the white rate for heart disease mortality. So a really big difference. And again, both rates improved, which is good, but the disparity widened, which is bad. Now, this is an extraordinary graph. This is female breast cancer mortality. In 1990, notice the rates were almost equal. The black rate was 20% higher. And actually, we have data that goes back to 1980, and then the rates were equal. This is from breast cancer, female breast cancer. But notice what happened over time. The white rate went way down. The black rate didn't improve at all. And so by 2005, the disparity was 99%. That means that from near equality in 1990, equality in 1980, that the black death rate from breast cancer was now 100% higher than the white rate. Another way of saying is twice as high as the white rate. So an extraordinary situation. And the other thing to notice is that the black rate didn't go down at all. No improvement whatsoever in these 15 years, which is extraordinary for us to make no progress in 15 years for a group of people. Just extraordinary. Here's diabetes mortality. Here the disparity narrowed just a little bit, but notice that it mostly narrowed because neither group changed or improved at all. The rates were about the same. The black rate went down just a little bit, narrowed the disparity, not a significant amount. So that was a wash. Things pretty much stayed the same. This is low birth weight infants, babies born at low birth weight. The disparity was a huge 141% in 1990, went down to 105% in 2005. So the disparity narrowed, which is good. It was statistically significant. But notice how the disparity narrowed. It narrowed because both sets of rates got worse. But the white rate got worse a little faster than the black rate, so the disparity narrowed, but it's a bad situation. So we did this again for all 15 measures, and we did it for both Chicago and the United States. I can't show you all of it today. Again, the paper is on our website if you'd like to see it. But by way of summary then, for the United States, the disparity increased in 6 of the 15 measures. Is that good or bad? Bad. It's bad for disparities to increase. We don't like that. Very bad. So the disparities increased. They went down in 8 of the 15 and stayed the same for 1. So 8 got better, 6 got worse. It's pretty much of a wash. But bear in mind, this is after the government spend billions and billions of dollars funding projects that are supposed to reduce disparities. And in the United States as a whole, according to this model or paradigm, which I think is a very good one, we've made no progress at all in the 15 years between 1990 and 2005. In Chicago, of the 15 measures, 11 got worse and 4 got better. So again, after spending billions nationally, millions upon millions locally in Chicago, things have gotten hugely worse. And in fact, in our paper, we called it a rapid backward propulsion. And that's what it is, just an awful situation. So disparities, black-white disparities, getting much worse in the city. I've been saying that. So these are some numbers, but if you come to think about what they mean and look at them from a different point of view, it's all quite interesting. So for example, in 2005, the last year of our paper, 34% of the black deaths, essentially a third of them in Chicago, would not have occurred if the black death rate was the same as the white death rate. 34%. In Chicago, that's a huge number. The percent is huge, but a huge number. It's 3,200 deaths a year in Chicago that occurred among black people as a result of that disparity or because of racism. 3,200 deaths. Just think of that, and divide that by 365, you get 9 deaths a day. So in 2005, and by the way, this was when we did the study, there's no evidence that things have gotten better. In fact, because of the economic situation, I bet my life has gotten much worse. But in 2005, 9 black deaths a day, on average, a day, every day, black people died simply because they didn't have the rates that white people did, because of racism. That's an extraordinary number, every single day. When we released this paper, came out in the journal, the media picked it up big time. So this was the whole front page of the Chicago Sun-Times at number 3,200. This was an article that appeared inside the Sun-Times, got a lot of attention. This was an article that appeared in the Tribune. These are basically the data that I've showed you. And let me just give you some different permutations of how this works. So I don't know if you're familiar with this, but Chicago is divided into 77 officially designated community areas. And not neighborhoods, but we know on a map exactly where they are. There's sums of census tracts. So there's 77 of them, and we've calculated the life expectancy for those 77. And if you calculate the life expectancy, as we've done, and you line them all up from lowest, which is worst, the lowest life expectancy, to the highest, which is best, the 22 with the lowest life expectancies are all black community areas. All black community areas, the first 22 of them. For example, Woodlawn, an all black community on the south side, had a life expectancy of 68 years, and the Loop 81 years. So a 13-year difference, and you could walk from one to the other. A 13-year difference in life expectancy. That's really, really terrible. And by the way, when you get to be my age, those 13 years really start mattering. So for kids like you, it won't, but for a person like me, it really matters. And so that's just extraordinary. Here's another example. In our paper, we calculated and demonstrated, and Shirley and I used to work on this a lot when we were at the health department, that the black infant mortality rate in Chicago was 14.1. If you look up online, 74 countries in the world have lower infant mortality rates than for black people in Chicago. 74 countries of the world. And people say, oh yeah, Denmark and Sweden, and that's true. But all these other ones as well that are not Denmark and Sweden. So just look at that. Jamaica, Argentina, Russia, Bosnia, Puerto Rico, Poland, and Cuba. In fact, just for another reason today, I looked up the infant mortality rate for Cuba, and it's 5.1. These rates are all given per 1,000 live births. So, but the moral of the story here is that the infant mortality rate for black people in Chicago is 3 times higher than it is for Cuba. And the median household income in Cuba is probably about $1,000 a year. So just think of what that means. And as a result of this disparity, again, thinking like we were thinking before, 3 black infants a week in Chicago die because of the disparity. Not 3 black infants a week die, but die because of the disparity, die because of racism. In the same way, more than 2 black women a week die because of this disparity in breast cancer mortality. I mean, again, you know, I know generally who you are, but just think about it. You know, these are our children. These are our grandchildren. These are our mothers and sisters and aunts, and so it's really, it's awful. Here's a context that I want to show you about for thinking about these deaths. So this article appeared recently in the New York Times, and it was about a cholera epidemic in Haiti, and I know you're aware of it. And the New York Times said it would take about $1 billion, CDC estimates, it would take about $1 billion to clean up cholera in Haiti. And they recommend that it be done, and of course so do I, and I'm sure every one of you recommends that as well. But it made me think about what's going on. So here's a situation. In Haiti in 2011, that one year, 7,000 people died from cholera, and there's about 10 million people living in Haiti. From 9/11, which we talk about all the time, of course 3,000 people died. And from racism in Chicago, which I've just shown you, 3,200 people died. So anyway, one can then calculate the rates. It's a little hard to understand there, but so I've drawn this graph. This is a bar chart, and this is the rates, the death rates from 9/11. This is the death rate from cholera in Haiti, and this is the death rate from racism in Chicago. So just look at that extraordinary situation, and I'll add one comment to it. So what are the proposed remedies? Well, for cholera in Haiti, the CDC recommends, and we all support, that we spend $1 billion to fix it. For 9/11, we spent trillions of dollars, murdered millions of people, and we bombed and killed everyone in sight. So that's what we've done in response to 9/11. And with respect to racism in Cuba, what have we done? Well, we've cut back everything. Reduced spending on public health, on all aspects, and black infants and women continue to die, and of course black men as well. And bear in mind, by the way, that 9/11 was a one-time event, hopefully. You know, the cholera epidemic in Haiti is a one-time event. It might last more than a year. We all hope not, but it could. But this racism in Chicago is every single year. Every single year. And just look at the steps we've taken to remedy this situation. So it's a very serious condition, very serious situation. I know you're all concerned with it. But again, it requires the profoundest concern and will to act and remedy this situation on our part. So all of that data I showed you came from vital records statistics that are kept by the city and state. But we've actually conducted a survey, a health survey in Chicago. I think it's one of the biggest surveys ever conducted. I don't have to go through all of this, but eventually we wound up doing it in 10 of the 77 community areas in Chicago. It's a very long story, but these are the 10 of them. Let's see, we're probably right now, where are we, in 28 or maybe 8? We're right around here, sitting there. But these are the community areas. This 29 is called North Lawndale, and that's where Mount Sinai Hospital, where I work, is located. It's walking distance from here. Anyway, here are some of our findings. So this is a percent of adults who are current smokers, and North Lawndale, again, is where Mount Sinai and my office are. It's an all-black community, 100% black, very, very poor. And just look at this. For men, 41%, women, 37%. So when you combine them, that's 39% of the adults smoke. It's twice the rate in Chicago and the United States. And to give you a sense of 39%, the last time the United States as a whole smoked at a rate of 39%, because it's now about 20%, was 1970. So another way of saying this is that North Lawndale, and several of these other communities, by the way, are 30 years behind the smoking cessation curve of the United States. 30 years behind that. Here are people diagnosed with depression. So this is we did it in a very interesting way. The blue part of the bar is, have you ever been diagnosed with depression? Which is a question that's asked on all the national surveys. And then in the yellow part of the bar, we gave a pencil and paper test, an index, that's used all the time by the Center for Epidemiologic Studies. That's what that CES stands for. And if people scored 6 or more, then they screen positive for depression. And so when you put them together, you have physician-diagnosed depression screening positive for depression. So just look at that, 31% combined, 32%, 40%, and so on. Huge levels of depression in these communities, huge levels. And by the way, I know, I'm not going to show you today, but the hospitalization rates for depression and mental illness, and they're huge as well. So large numbers of people are depressed. These are all very poor communities. By the way, Norwood Park was a rich white control community, and they're not very depressed at all. So I don't know why all these poor people are depressed. I don't understand why they're just not dancing in the street and all of that, but there's a huge amount of depression there. This is the percent of children who were overweight or obese, and just look at this. For example, I'll just talk about North Lawndale. It's the same everywhere except in Norwood Park. And in North Lawndale, 15% of the children were obese, 53% were overweight, altogether 68%. More than 2/3 of the children have trouble with their weight, overweight or obese, compared to something like 26% in the United States. Absolute huge proportions, and again, I could tell you more. This is one of the more amazing slides, because on our survey, in a different part of the survey, we asked the parents, how do you perceive the weight of your child? Do you think your child is underweight, about the right weight, slightly overweight, or obese? These are the proportion of parents of overweight or obese children who said their children were the right weight or underweight. And notice that virtually all of them misperceived the situation. So like here, this 90% in Roseland, which is a South Side all-black community, 90% of the parents there said that they thought their child, who we know from our data, was either overweight or obese. They didn't say their child was overweight or obese. We know it from our calculations. But they say that child was the right weight or even underweight. So a complete misperception of the situation. And if we ever want to put interventions in place to make things better, and I hope we do, then we're going to have to help people understand what the weight situation is. You know, if you hang up a sign and say you want to come to a smoking cessation class, everybody knows whether they smoke or not. And they may or may not tell us the truth, but they know. But imagine you hang up a sign and say, would you like help with your obese child? And all the parents say, well, cool, that's not me, because my kid is fine. So it's a very interesting dynamic. Here are children with asthma, same kind of thing, 28%, huge, more than 1 out of every 4. Again, we did it partly with a physician diagnosis and partly with an index that we collected data for. When we did it by race and ethnicity, Puerto Rican children actually had the highest rate, overwhelmingly, 34%, more than 1 in 3 of Puerto Rican children had asthma, 25% for black children. Anyway, I'll let that go on. So now, here's the situation. I'm professionally an epidemiologist, and so many of my colleagues, and I've never quite been able to understand this, they do research, some of them the same kind of research we do, some of them different, and they find conditions and like these, something like this, and they write articles, they publish the articles, they get promoted and get rich, like me, and then they move on to the next research paper and never do anything about the problem. And to me, that's always been the most extraordinary kind of behavior. It's like, so we refuse to do that at Mount Sinai and at the Sinai Urban Health Institute. It's a strong belief that we do the research to find out what's wrong so that we can try to make it better. Otherwise, in my point of view, why do the research? So we've developed what we call the Sinai model. We do excellent research, document the disparities. We disseminate the findings to lay audience and professional audiences. We try then to assemble resources for interventions, raise money. We meticulously evaluate what we do. And so if we fail, we say that. We're not ashamed to do that. We try to be transparent. And we want eventually to improve the health of vulnerable communities. So this is what we call the Sinai model. And by the way, we've written a book about it. So I have this book here. I brought a few copies with me. They're unfortunately very expensive, but I have 4 copies if anyone wants to buy them. You can see me after talk. And by the way, they make excellent holiday gifts and really great stocking stuffers. So if any of you would like to do, also, if you read it page to page, you could eat as much chocolate as you want with no adverse effects afterwards. So I strongly recommend the book to you. And let me show you, I'm just going to show you one example of the work we do to try to make things better. I mentioned the problem with breast cancer before, so that's one area, but I'm going to skip over that. And let me talk to you about pediatric asthma, because I want to stop so we can talk a little bit. So if you remember, we found huge proportions of children with asthma in the communities that Mount Sinai serves and works in and around. And so we decided we needed to do something about it. I showed you this also by race and ethnicity. And this is very interesting as well. A lot of adults smoke in these communities, and they smoke in the houses of a lot of the children with asthma. And if you think what's the worst thing you could do to a child with asthma, it'd be blow smoke in its face. And yet that goes on all the time. So we thought we just had to do something about it. So we began to disseminate our findings. So here, for example, in the Sun-Times there was an article, the Chicago Defender covered it, and really there's a very good article talking about the disparities. Here are more of our dissemination efforts, our publications in the area. And so we've been quite active in this. And in 12 years, we've received a lot of funding from local foundations, from federal agencies like CDC, from the Illinois Department of Health, and from HUD, and so on. We've enormously, and I'm going to show you the data in a second, this is a summary slide, improved child health. The programs have been enormously cost effective, and I'll show you more about that and talk about the sequelae. But for example, here's one of our programs. It's called Healthy Home, Healthy Child. And what we do is we hire community health workers, people from the community. We train them in asthma. We give them full-time jobs. They get benefits. They get used to working. They get insurance. Their children get insurance. It's a wonderful way to proceed. And then they go into the homes of these families with children with asthma, and they help them clean up the home. So here's an example, for example, of the findings. The daytime symptoms of children down, this asterisk again means statistically significant, down a significant amount. Nighttime symptoms, down a significant amount. Days needing rescue medication, down a significant amount. Look at this, ED visits from an average of 3.5 a year to 1 a year. Hospitalizations from 1 a year to almost 0. All these changes statistically significant. Quality of life greatly improved, and on and on and on. So again, we evaluate things very carefully. You know, we're all epidemiologists, and we take this very seriously, and the findings have just been staggeringly successful. We've won a lot of awards. Here are some of them. I won't go through them all, but national awards. Here are a couple more. Now this slide I want to talk about for a moment. So when one of the programs ended, Healthy Homes, Healthy Child, it was a 3-year program funded by CDC. So we had a big celebration out in the park that's across the street from our hospital, Mount Sinai. And about 300 people came. You know, we got food and served sandwiches. And we rented for the children these big, huge, room-sized, building-sized balloons, you know, that they blow up, and the kids could play on, you know, so they could bounce on them and go down slides. But they're made out of plastic. And so there was one rule, and that is that the children couldn't wear shoes because for fear they would puncture the balloons. The children, of course, were not interested in that rule and didn't want to take off their shoes. And so throughout the day, our staff, the community health workers and others, were arguing with the children that they had to take off their shoes to play in the balloons. And the children would say, no, I'm not going to take off my shoes. And they say, you have to take off your shoes. And everybody had their hands on their hips, and they were arguing back and forth. And I was standing watching it all, and I realized, and I don't know who else did there, I mean, it wasn't so profound, but when we encountered these children, and this is not an exaggeration, many of them could not get off the bed or the couch to answer the door. And here they were bouncing around, running and jumping and playing like children do. And it was just the most extraordinary thing in the world. And really, seeing it was just tremendous. Anyway, there have been any number of reports and dissemination efforts and things like that. These are a number of conferences we've presented our results at. This is a local community newspaper, the North Lawndale Community News, front page article about our project. Our staff doing lots of good things, more of our awards, different names of the projects. But let me show you the cost-benefit analysis of this. We've evaluated this very precisely, and if anything, so the saving for every dollar we spent, and this is over 12 years in different programs averaged together, for every dollar we spent, we saved $7 in healthcare costs. That would be an average of $3,000 per year per participant. That means if we served 1,000 children, just multiplying that out, it would be a saving of $3 million a year. In Illinois, in the state of Illinois, there are 120,000 children with asthma who would be eligible for our program, who are funded by Medicaid for their health care needs. If Illinois would put this program in place for all of the children that are eligible for our program, they would have a cost savings of $1.8 billion a year. $1.8 billion a year. These numbers, by the way, are conservative, so that is, I think the real values are even much more dramatic. And so you say, as did I, well, this is wonderful. We have a program that's helping children breathe and thrive, literally saving some of their lives, and saving literally, or with the potential to save billions and billions of dollars. So of course our politicians are going to fund this, because they're all wise elected officials leading the way. And you, of course, know the end of the story. Not one penny for funding for this program. And again, if it just improved health but wasn't cost effective, I would still argue they fund it. But in addition to that, it will save them all the money. And I was speaking to a local legislator who's actually a very nice, good person, sincere. And I said to her, what's going on? And she said, Steve, you don't understand the mentality in Springfield. In order to save the money, we would first have to spend some, and no one's going to spend anything. So really, I'm telling you, honestly, I don't know if you've ever seen a child with severe asthma, but they can't hardly breathe. They can't get out of their couch, they can't go to school. Frequently, they go to the emergency room in the middle of the night, which means that the whole family has to get up and go with them. The next morning, the kids can't go to school, the parents can't go to work, on and on and on. But we, of course, won't do anything to change or improve the situation. So I'm going to skip the diabetes stuff because it's time for me to stop, but similar concept. So, we have to go about this, we think, with serious community engagement, working with community-based organization, hiring these community health workers. These community health workers, by the way, are just the best thing ever. I mean, not only we give them jobs, we give them insurance, benefits, the kids have benefits, they get used to working, but also they become a resource for the community. I can't tell you how many times they've come to me and said, I was shopping yesterday evening in the supermarket, and someone came up to me and said, hey, aren't you that diabetes lady? Well, I have this question. Or aren't you that breast cancer lady? Or aren't you the one who tells people how to get mammogram? So they become resources for the community. And again, one would have to push to think of a dumber thing than not to fund community health workers. Again, it's great for them, it's great for their families, it's great for the community, and it's enormously cost effective. So of course, we don't do it. But go and get an MRI and see what happens. You know, $8 or $12 million for that. So we all know that's the problem, but so these are, we do a lot of stuff out in the community. This, I don't know if you can see this very well, but this is us at a Puerto Rican Day parade. By the way, this person here is Lisa Madigan, who very likely is going to be the next governor. So she joined our contingent. She didn't know us, but this is Cynthia Soto, a state rep, and their friends, so they came. This is us handing out leaflets in the parade, and check out this guy's legs. Very impressive kind of a situation. Anyway, this is around breast cancer and on and on and on like that. Demonstrations that we've led demanding more funding for mammograms in Chicago. 500 people showed up that day. That's the State of Illinois building. We led it. We called for it and led it. So anyway, I won't go through a lot of that. So let me just end now with a few slides. So what do we do about it? Well, first, I think we have to be clear on the way racism works. This absolutely rampant insanity that we are living in a post-racial society, it's gobbledygook beyond human comprehension. I mean, just tell all the babies who are dying of racism that we're living in a post-racial society. So we have to understand that. A lot of wonderful books have been written about that. Here's a book called More Beautiful and More Terrible. It's a wonderful book about the way racism works, and you might want to buy that. Here's another great book, White Like Me, which is all about ways racism works. Another one, Whitewashing Race. These are all wonderful books. Again, I know I'm going fast, but they're in my slides if you're interested in them, and I think you should get them all. Anyone know who Lorraine Hansberry was? Yeah, anyway, she was a playwright and an essayist, and among other things, she wrote A Raisin in the Sun, maybe the greatest play ever written, but many other things as well. And she was from Chicago. Just an amazing human being. She wrote a lot of different essays. By the way, she once had a meeting with other black people with Robert Kennedy, you know, the brother of the then president, and Lorraine Hansberry spoke so firmly to him that he was infuriated and stormed out of the room. But so Lorraine Hansberry was literally made out of steel. And she has this quote in one of her essays, which I love. She says, "This is a matter of admitting the true nature of a problem before setting about rectifying it and pretending to is of utmost importance." So really, we have to understand the problem, we have to recognize it, and whenever possible, we have to speak about it. This is Ida B. Wells. Does anybody know who she was? Okay, so Ida B. Wells was born a slave and in Tennessee, and in her early years, she grew up in Memphis, and when she was about 5 or 6, slavery ended. And she was a writer, so she founded a newspaper, and she became the leading opponent in the United States and, of course, in the world against lynching. And she spoke out about it constantly and was hated for doing so, both because she was black and because she was a woman. And so first they burned down her printing press, and then she started again, so then they burned down her house. And by the way, then she moved to Chicago, where she spent the rest of her life, and she traveled the world speaking in opposition to lynching. And at one of her press conferences, a reporter said, "Well, Ida, what is it that you people want anyway?" And she thought about it for a moment, and then she said, "Why, everything, of course." And what would be the reason why black people, or any group, could not have everything that we have? What is the reason for that? You know, is anybody going to stand up and tell the truth about that? I mean, it's really just obscene. W.E.B. Du Bois, of course, was a famous everything, activist, historian, journalist. He helped found the NAACP and just wrote 14 books in his life. And one of the books he wrote was called The Health and Physique of the Negro American. They called it a sociological study. We probably would call it an epidemiologic study today. And they studied the health of black people and white people, concluded that the health of black people was worse, was inferior, and said that that was because of racism and poverty. And the kicker to that is that that was written in 1906, 107 years ago, and here we are still talking about the same thing. So, you know, we've got to fix things. This is Doña Consuelo Cortier, Puerto Rican woman, the national poet of Puerto Rico for a while. And she said, you know, we have it all wrong when we use the slogan, live and let live. She said, that's not right. Rather, our slogan should be live and help to live. And so that's, I know, what you all have devoted your lives to. It's what we try to do at Mount Sinai in the Urban Health Institute. So there's a lot of stuff to do. These are suggestions, you know them all. But really, the one thing, Shirley Fleming asked me to answer all of these questions, as she always does, and I probably didn't answer any of them, but I did write them down, Shirley, anyway. So anyway, there's another picture of the book for those of you who want to buy 8 or 10 copies. So I thank you very much for your kind attention. If you have any questions, I'd be glad to answer them.